Yang Berhormat Dr. Seri Dr. Dzulkefly Bin Ahmad, Minister of Health, Tan Sri Dr. distinguished participants, ladies and gentlemen. Very good morning to all of you and welcome to the Malaysian Healthcare Conference. I'm delighted to extend a very warm welcome to our Honourable Minister of Health and to thank Yang Berhormat for taking time off your very busy schedule to be with us here this morning and to deliver the opening keynote address. We thank you, sir, for being with us and for your willingness to share with us your vision and your perspectives on the future of Malaysian healthcare. The Minister has been focusing a lot on value-based healthcare, and this is one of the key subject areas that today's forum would be discussing, and we look forward to the Minister's keynote address on this important topic of values-based healthcare. In the health industry, we face many challenges. The need to provide healthcare for all continue to be a growing demand of all Malaysians, and the government has a difficult challenge of meeting this growing demand for affordable, accessible, and quality healthcare. At the same time, I think the healthcare sector is moving into healthcare 4.0 in the same way as industry are now moving into industry 4.0 with a greater impact of health and medical technologies. We also see there is growing demand for medical tourism in Malaysia, and we are one of the leading centers for visitors from overseas to seek medical treatment in the region. Another important challenge that we face in the healthcare sector is the whole notion of training of professionals and upgrading of our healthcare workers at all levels in both the public and private sectors. We do hope that today's forum will be able to enable an open discussion on these and many other challenges that the healthcare industry faces. I would like to once again thank our Honourable Minister for taking time off his very busy schedule to be with us today. Thank you also to all of our distinguished speakers for your willingness to participate with us today and to share your wealth of knowledge and experience. Finally, I'd like to thank our corporate sponsor for today's event, Napier Healthcare, for your support of this healthcare conference. Thank you very much.
Thank you, Lady MCs. Yang berbahagia Tan Sri Michael Yeoh, President of the Kingsley Strategic Institute. Yang berbahagia Tan Sri, Datuk Excellencies, distinguished guests and distinguished speakers, members of the media. Ladies and gentlemen, may I begin by Assalamualaikum warahmatullahi wabarakatuh and a very good morning to all. It is indeed a great honor to be here at this conference to deliver the keynote address on the topic optimizing outcomes and creating values in a changing healthcare landscape. I would like to firstly thank the organizing committee for this opportunity and for choosing the theme, which is apt and relevant with current healthcare climate both locally and globally. As Malaysia continues to develop rapidly, the issues facing the more developed countries will increasingly become important for Malaysia. Issues such as escalating healthcare costs, diseases related to lifestyle, increasing numbers of the elderly in the population who will require more and expensive healthcare, the introduction of new technologies, sometimes disruptive, and the ever-increasing consumer expectation are familiar issues. concerns with issues of social justice will surely increase. The challenges and pressures from these and other issues are already with us, even if they are not generally recognized. Equity has always been important in Malaysia's development and especially in health. Malaysia's existing healthcare system, comprising of both the public and private, is a two-tier system, the perennial dichotomy. The private system mainly caters for the urban population and those who can pay, while the public system provides access to everyone, including civil servants, with token payment being imposed. A two-tier system is inherently inequitable and inefficient. The existing two-tier system, while inherently inequitable and inefficient, has served Malaysia well so far. But will it be sustainable in the longer run? The existing healthcare system, like most around the world, has been organized around acute and often catastrophic illnesses. The healthcare system, which to many is actually a sick care system, treats the patient during this episode until they are well again. Ladies and gentlemen, in many countries, a casualty approach to health insurance has been developed to fund healthcare based on the fundamental unpredictability of disease and injuries. Expensive healthcare systems have been developed based on the acute care model. However, major advances in diagnostic and therapeutic technologies have enabled earlier intervention in chronic diseases like heart diseases and cancer, and increasingly more patients can be treated on an ambulatory basis without hospitalization. In the coming decades, these acute care model and existing health insurance concepts, as well as society, will have to deal with the increased predictability of risks of disease. Major advances in immunology, predictive genetics, and human genome will make it possible to predict disease in many people long before symptoms emerge. The present paradigm of diagnosis and treatment will be replaced by prediction and early management of risk factors and illnesses. With this development, the casualty model of healthcare insurance becomes fundamentally flawed. I think about it and you'll come to internalize this if you care to ponder. The manner in which resources are mobilized to support the healthcare system and how it is organized for services delivery and its influence on health status is also important for it influences on the other aspect of the country's social, economic, and political well-being. Under the budget 2019, about 29 billion has been allocated to the health ministry, which included 10.8 billion allocation to provide for medicine and upgrade of the quality of health services of clinics and hospitals. These allocations will help to cover the overall objective of healthcare system, which include, among others, improving health status, promotion of social well-being, and ensuring equity and access to healthcare, and ensuring efficiencies in the use of resources, allocative efficiencies, enhancing clinical effectiveness, improving quality of services and patient satisfaction, and fulfilling patient expectation, and ensuring sustainability of the system. This is rather a long speech. I wish I can speak like Tan Sri, short and sweet. Spending on healthcare almost invariably grows faster than GDP. You should know that. The rate of growth of healthcare spend has exceeded the GDP since record began. Moreover, spending and economic recession are closely linked. Malaysia's healthcare industry spending is expected to reach about 80 billion by 2020. That's right. That's the truth. The industry spending, which recorded 52 billion as at end of 2017, has increased, fueled by the demand for healthcare services and the emergence of new care models beyond traditional hospital settings. Macroeconomic factors like aging population or insufficient public funding are also challenging both receivers and providers of healthcare. Adoption and penetration rates of clinical information systems vary greatly. In fact, the number and size of buyers varies from country to country and is not necessarily dependent on the size of the country, but rather on the structure of the healthcare system. Additionally, purchasing behavior is shifting toward more coordinated joint purchasing, which provides for economy of scale. There is also increasing demand on the healthcare delivery organizations, and this is happening in every country. People live longer thanks to advances in understanding of causes of disease and consequent improvement in diagnostic techniques and treatment. The average life expectancy or longevity in Malaysia has now reached 75 years for both, average, male, female, and it continues to lengthen. However, not only are people able to live longer, but increasingly people are living longer with chronic diseases. Unfortunately, diseases are age-related. Ladies and gentlemen, there is growing consensus among stakeholders in the multi-million-dollar global healthcare sector that the industry faces a serious value problem. Despite decades of effort to control spending, costs continue to rise at roughly double the GDP growth in most countries, in most developed countries. In addition, there are wide variation in healthcare outcomes across hospital, region and countries with no clear causal relationship between money invested and health delivered. That is unfortunate. The national health systems that spend the most money do not necessarily provide for the best care. And there is considerable evidence that a substantial portion of the healthcare spending is, quite simply put, wasted on avoidable medical complications, medical things that are medically unnecessary, or caught in inefficiencies in administrations. This new focus on value in healthcare seeks to address this interlocking problem holistically. It does so by taking a principle that has guided healthcare professionals throughout history, namely doing their best for patients given the resources available and making it the centerpiece of health system and design and organization. Value-based healthcare makes the delivery of improved health outcome for the same or lower costs is the primary objective of global health systems. The approach is founded on a systematic measurement of health outcomes and of the costs required to deliver them for clearly defined subpopulations. For example, all patients who suffer from a given disease or condition, such as type 2 diabetes, or who share a similar risk profile, such as the multimorbid elderly, these and others as well, where you have teams of clinical specialists using this outcome and cost data to develop customized intervention to improve the ratio of outcomes to costs for each patient group over time. By aligning industry stakeholders around the shared values of improving healthcare value, value-based healthcare has the potential to deliver substantially improved health outcomes at lower cost than most health care systems around the world. This approach also improves access to appropriate care, defines relevant innovations in treatment and care delivery, and provides major new business opportunities for healthcare organizations in both the public and the private sectors. The value-based approach to care rests on three foundational principles. A, measuring systematically the health outcome that matter to patient and the cost required to deliver these outcomes across the full cycle of care. B, tracking those outcomes and costs for defined population segment on an ongoing basis. And finally, developing customized intervention to improve value for each population segment. 4 enablers are key to accelerating the adoption of value-based healthcare. 1, health informatics. Health informatics to facilitate the easy collection, analysis, and sharing of outcomes and cost data. B, benchmarking. Research and tools to leverage data on outcomes and costs for clinical practice improvement and innovation. And 3, value-based payment. Value-based payment, not fees for service only. It's value-based payment to create incentives for all stakeholders to focus on value. And of course, finally, innovation in organizing care delivery to improve coordination across the health system. Because healthcare is a highly regulated industry, public policy has a critical role to play in enabling the value-based transformation. As policymaker, the ministry may mandate the tracking of health outcomes and set standards for data collections, analysis, and eventually transparency. We do realize and acknowledge the need to balance the trade-off between patient privacy and data sharing. That is a precarious issue, but you can always have the approach of anonymized data that you could share. Enable cooperation, coordination, and partnership along care pathways while protecting against conflict of interest. Establish new payment models that support improvement in patient value, and make it easier for pharmaceutical and medical technology companies to be more accountable for and contribute more actively to healthcare value. I read here, in India, the Aravind Eye Care System, for example, a network of hospitals dedicated to providing low-cost, high-quality cataract surgery, combines systematic tracking of health outcome with an integrated approach to care delivery. The resulting healthcare outcomes are equivalent to those of the world's best providers, and more importantly, at approximately 10% of the cost per surgery in the United States. That is surely very commendable. In Germany, Martini Clinic, a prostate cancer center at the University Hospital Hamburg-Eppendorf, collects comprehensive data on patients' healthcare outcomes, including documentation of all post-surgical complications down to the level of individual surgeon, and uses the data to continuously improve its performance in prostate cancer care. As a result, the clinic's rate of severe erectile dysfunction 1 year after surgery are less than half of the national average, and instances of urinary incontinence are about 1/7 of the national average. That would put smile to both husband and wife. In Sweden, more than 100 quality registries covering the majority of national health expenditure systematically track health outcome for patients suffering from a specific condition or disease. The accumulating body of data has allowed Swedish clinicians to identify which providers provide and deliver the best outcome, codify the clinical best practice, and share them with other providers, thus improving average health outcomes over time. A recent study demonstrated that 30-day mortality after acute myocardial infarction is 37% higher in the United Kingdom than in Sweden. There you go. Immediately you get the return on investment. 37% differential outcome measurement. Researchers are leveraging the providers' networks affiliated with Sweden quality registries to conduct clinical trials, evaluating the effectiveness of treatment and procedures at roughly 10% of the cost of traditional clinical trials. Tan Sri, this is surely, amazing and very promising, to say of the least. The above example suggests the potential of a relentless focus on value to transform the healthcare sector. National health system face an extraordinary opportunity to deliver substantially improved health outcomes to patients and at significantly lower cost than today's health systems. Given the size of healthcare budget in most countries, such improvement promise to significantly raise national productivity through more rational use of resources and by allowing more people to stay at work longer and contribute to society. So the final national outcome is a productive society that is capable of performing and deliver a higher income economy and a higher performing economy. The value-based approach to care will also improve access to appropriate care, spurs innovation in treatment and care delivery, and provides major new business opportunities for the public, for both the public and the private sectors. The ministry will cooperate with various parties to ensure that the outcome and value will truly transform the Malaysian healthcare sectors. That I vouch to do, and I will always be there to facilitate this transformation and this reform. Ladies and gentlemen, may I just, it's really very long, but I think, but they are still with me though, Tan Sri. Let me just quickly finish the last few para. Recently, my ministry has launched a different B40 scheme called the National Health Protection Scheme, Peduli Kesihatan for the bottom 40, bawah 40, called PeKa B40. Focusing on health screening for early non-communicable diseases and NCDs for those aged 50 and above. Don't ask me why 50 and above. It's just a question of choice because we have only got 100 million. You're supposed to get more. But okay, let's finish that first and we'll address the other, age segment group. The scheme is expected to benefit 800,000 people and start with an allocation of 100 million. I tell you, this is not just the Peduli Sihat of Selangor. This has got a evidence-based conviction by way of where it's coming from. It is actually looking at the MHSR, the Malaysian Health System Research, done by the Harvard University and our MOH. And one of the things that I personally found out in that longevity, while our comparators, when our peers are all still, having a good outcome by way of a linear kind of curve, ours is already plateauing. And why is it plateauing is my concern and my challenge. And that's where I'm coming from. When NCDs is truly the causative factor for this, I have to address it. For years and decades, we have been giving lip service to talking about primitive, preventive medicine. When it comes to money and allocation, you don't see it. There's a mismatch. The system has always been on curative, secondary and tertiary care. Notwithstanding the need for that. But you have to be committed to the primary care, where each and every individual's need to be seen and managed by a family medicine physician. That's where I'm coming from. And we had a discussion earlier about why the electronic medical records, when information move with patient, for both a horizontal integration of all clinics and as well as vertical integration with all hospitals. And I, for one, would want to see not just the public facilities, but as well an enhanced collaboration between public and private. That's the way to go, Malaysian, new Malaysia. I speak this with all my passion because this is what I want to see roll out. For the time being, it's always about larangan merokok, larangan merokok, larangan merokok. And I get the brickbat every day. You laugh, I got to suffer. Together with the mySalam, which provides coverage for recipients who are admitted to a government hospital or diagnosed as having one of the 36 critical illnesses, covered by the plan. These 36 critical illnesses covered by the scheme includes cancer, of course, heart attack, ischemic heart diseases, coronary, vascular diseases, and Alzheimer, to cite but a few. Recipients that are diagnosed with one of the illnesses will receive 8,000 as a one-off payment. And if they are admitted, they will get a kind of a income replacement kind of thing, where they are paid 50 ringgit per day, a maximum of 14 days, thereabout is about 700 ringgit. You may think that it is peanuts, but to the B40, evidence-based again, the Khazanah Research Institute found out that B40, and the majority of them, could only last. Should there be any kind of shock, they could only, in the sense of any family, brought down with cancer, stroke or whatever, as the breadwinner, families of the B40 could only last for 2 weeks. That's how much saving they have. That literally is how much saving they have. And this is the majority of B40, mind you. So, may not sound much to you, but to the B40, this is surely very helpful. And the new Malaysia, the new government, we vouch to be looking at the B40. And among other things, we have our PeKa B40 and now mySalam. 8,000 one-off payment lump sum is surely very significant to the families of the B40. I remind you that. Hence, the government will use the 2 billion contribution from an insurance company that you are all well known to you now, for the mySalam scheme to pay for the social protection insurance scheme for eligible individuals at thereabout 112 per person per year. And we would wish to see more of such, capitans of the insurance industry coming on board with us. We more than welcome. I'm saying this on behalf of my good friend, Minister of Finance, because we want to see this. The fund is expected to offer medical protection to 3.69 million individuals from the B40 group that will last thereabout for 5 years. The mySalam scheme and the PeKa B40, which share the same social principles such as expanding healthcare access, reducing cost of living, and increasing the welfare of people, will complement each other in improving access to healthcare for the B40, leaving no one behind, and in the effort to achieve the universal health coverage, UHC, and the SDGs. It may be a humble or a modest, if I may say, effort, but surely it means significantly to the B40, especially when you handle preventive medicine. That will directly avoid the complication of the NCDs. The increasing number of patients having to go for dialysis as a result of uncontrolled diabetes mellitus, amputation is a result of ulceration, blindness as a result of secondary glaucoma and retinopathy, whatever. So all these seriously impact on the heavy burden and the double burden of maintaining or healthcare financing of the NCDs. Notwithstanding communicable diseases, the re-emergence of multi-drug resistant of tuberculosis and whatnot, and even dengue for that matter. So, if I may say, the mySalam scheme, again, and the PeKa B40, which share the same social principle of expanding healthcare, reducing cost of living, and increasing the welfare of the people, will complement each other in providing access to healthcare for the B40, leaving no one behind. Ladies and gentlemen, before I conclude, allow me to share a testimony as a reminder that Malaysia has, in fact, the best healthcare in the world. Scoring 95 points out of possible 100, full mark, Malaysia takes the top spot in healthcare category in the International Living Annual Global Retirement Index of 2018. For 2 years, we remain to be the best destination. But let me also quickly remind you that I care more for what the riot look at me and our healthcare facilities, rather than the foreign retirees that has come to get access to our very affordable quality healthcare. Make no mistake in that. It augurs well for our medical tourism, surely. As for 2015, the revenue generated via medical tourism stood at 1 billion, contributed by more than 850 medical travelers to Malaysia. In 2016, the industry's contribution to the GDP exceeded 1 billion, and the government aimed to increase this to 1.3 in 2017. That has really, hopefully we achieved that. Then the healthcare industry is eyeing a revenue of up to 5 billion to Malaysia's past performance in terms of relation to our gross domestic product, GDP. This is expected to increase in tandem with our 2020 target. The total export for medical devices is also expected to reach 18.4 billion in 2020 from the position from the RM 11.3 billion registered in 2017. Similarly and additionally, the pharmaceutical segment also saw its export growing from 577.8 million in 2011 to now in 2017, 938.5 million at an average annual rate of 8% increment per year. Registration of the generic product also reduced to 90 days compared to 220 days, for the prescription drugs. And this will really augur well with the ease of doing business. So with that, ladies and gentlemen, we stood firmly behind the multi-sectoral approach and vision for the Alma Mater Declaration 1978 to achieve health for all and leaving no one behind. And with that, I conclude by thanking again the Kingsley Strategic Institute, Tan Sri Michael Yeoh, and all corporate sponsors that have made this possible, and thank you for inviting me again. I thank you for your attention to this very long speech. I thank you again. Assalamu alaikum wa rahmatullahi wa barakatuh.